Hi everyone, my name is Gurjat Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. And I'm pleased to welcome all of you to today's session on peripheral T-cell lymphoma. We appreciate those who have been able to join us live today to learn more about the disease-specific biology of this lymphoma subtype, as well as novel treatment options available for Canadians. So before I introduce the speaker, I just want to provide some guidance on the Zoom software for this session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you have any questions, please save it for the T-cells lymphoma Q&A session that follows this presentation. So without further ado, to introduce our speaker, today we have here Dr. Carrie Savage, who is a professor of medicine at the University of British Columbia and has been a medical oncologist and clinical scientist at BC Cancer with the lymphoma tumor group since 2003. Dr. Carrie Savage has obtained her medical degree at the University of British Columbia in 1996 and also received a Master's of Science in Epidemiology at the Harvard School of Public Health in 2004. As you may know, she is also the chair of this year's patient conference and sits on the Scientific Advisory Board for Lymphoma Canada. So thank you so much, Dr. Savage, for joining us today, and I'll hand it over to you.
Thank you so much for that kind introduction, and it's a pleasure to be involved in this conference and also to discuss peripheral T-cell lymphomas, a subject that's near and dear to me. So in the next about 45 minutes, I'll give a brief introduction to peripheral T-cell lymphoma. I'll discuss some of the subtypes and study language so that the subsequent slides make sense. I'll talk about treatment evolution and in recent years, moving towards more personalized therapy. And then I'll talk about options in the relapse setting, as well as approved drugs and some ongoing studies. So by way of introduction, I just want to give you a brief background on T-cell development. You probably saw some of this already in the earlier presentations. But T-cells start in the bone marrow and then develop in the thymus, and the active worker T cells are CD4 and CD8. So something can go awry along the way to develop lymphomas, and in this case, peripheral T cell lymphomas develop from the CD4 and CD8 cells. We call them peripheral because it means that they're in the periphery as opposed to the thymus, and that's to distinguish them from what we call the precursor T-cell neoplasms, which are TALL or lymphoblastic leukemia or lymphoblastic lymphoma. The other term that we'll use for peripheral T-cell lymphomas is mature T and NK cell neoplasms, and they're exactly the same thing. And to make things simple, we usually just say PTCLs because it's much easier to say. So how do we diagnose and classify lymphomas? There's a number of pieces of information that a hematopathologist will use to assign a name to a specific lymphoma. It includes what does the lymphoma look like under the microscope or morphology. They do different tests to determine what the cell type is. Is it a T cell or an NK cell or B cell? And so for the purposes of this discussion, we're talking about T cell and NK cell. And the B cell lymphomas are discussed in other talks. In some cases, they do genetic testing. So they look for the presence of a T cell receptor using molecular diagnostics. And in some cases, there might be a special test to look for a translocation. And more recently, there are some labs that are doing mutational analysis. And this is something we hope to bring to BC Cancer in the near future, as it can help in diagnostics and it may in the future help with treatment. There are some viruses associated with PTCL, so the best described is Epstein-Barr virus, and that is associated with a specific type of T-cell lymphoma called NK T-cell lymphoma. HTLV1 is a relative of HIV, and that is associated with a rare subtype of T-cell leukemia lymphoma. And in some cases, the clinical behavior actually is helpful in diagnosing T-cell lymphomas. So we do need a discussion between the clinician and the pathologist to come to a diagnosis in some cases. So some of the tests that they do are helpful in diagnosing a peripheral T-cell lymphoma, but in other cases it might help to guide therapeutics. And the best example is CD30. Anaplastic large cell lymphoma is one of the subtypes of peripheral T-cell lymphoma. And by definition, it is strongly and uniformly positive for CD30. So that brown stain is all lighting up where CD30 is. And there are some other PTCL subtypes that might also express CD30. And I'll be talking about in subsequent slides that there's a new therapeutic against CD30 called the brentuximab vedotin. So this has also become a therapeutic target. We talk about endpoints, and particular survival endpoints in cancer and including lymphoma. So I'm just giving you a quick snapshot of some of the language we use because I will be showing some survival curves in upcoming slides. So this is an example of a progression-free survival and an overall survival curve, and it describes what happens in a population as opposed to an individual. So when we discuss prognosis, we take information like this and say this is what we'd expect to happen in a population of patients. But of course, we can't always say what's going to happen to an individual that's sitting in front of us. Progression-free survival also includes relapse events as well as death due to lymphoma, whereas overall survival is just death, and it's actually due to any cause. So in studies, we report these and we compare them between studies. We compare them between lymphoma subtypes, and we also use these endpoints to look at the benefit of new therapeutics. So what we want to be seeing is 100% progression-free survival and 100% overall survival. So obviously that's the best. But we can judge whether the outcome has improved by seeing this curve shift upwards. I also just want to show you a quick snapshot of how we measure response, which really means shrinkage of the lymphoma. So I have here a CT scan with a lump in the chest area, and then before and after. In contrast, the PET scan lights up where there is cancer, and it can be a very useful adjunct in some peripheral T-cell lymphomas. When we're evaluating clinical trials, something that sometimes is shown in a paper is called a waterfall plot, and each one of those bars actually refers to a different patient. And what we want to see is the bigger the bar on the lower side, the deeper the response. And the terms we use for discussing response are complete response, meaning the cancer is all gone, partial, meaning it's 50% shrunk, and then we usually combine that together to give an overall response rate. And then stable disease, there's no change, and progressive disease, it means it's grown. So shifting back to the umbrella of peripheral T-cell lymphomas, this is a really complicated group of diseases. There's 30 different subtypes, and this is also why even hematologists shy away from it because they're all very complex and unique. So it's not just understanding one disease, it's understanding 30 diseases. In North America, typically there's 3 main common subtypes: peripheral T-cell lymphoma not otherwise specified, or NOS, angioimmunoblastic T-cell lymphoma, and anaplastic large cell lymphoma, which I've already referred to. So most of my discussion today is centered around these subtypes, but I do reference some of the other ones where appropriate. Peripheral T-cell lymphoma not otherwise specified, we sometimes call this the wastebasket diagnosis, and it just means that after doing all these tests, the hematopathologist can't slot it into one of the specified category. And this group actually is getting smaller and smaller with each classification update as we get more sophisticated tests to tease out new entities. So I think this is likely going to disappear as we split off and understand new lymphoma subtypes. And so this angioimmunoblastic T-cell lymphoma has actually become a broader category of what we call T follicular helper lymphomas. And this is actually already a good example of that PTCL NOS category getting split off. So we've recently recognized that there are cases that we would have called PTCL-NOS, but we now have under this umbrella of T follicular helper lymphomas if they have two of these 5 markers that I've listed here positive. And that actually becomes very important for us clinically because it can actually guide therapeutics. And I have some examples of that in later slides. But for the purposes of this discussion, it's just important for clinicians to know that this is no longer one subtype, it actually is 3. Anaplastic large cell lymphoma was recognized some time ago to be 2 different subtypes, one called ALK positive and the other ALK negative. The ALK positive cases have associated a translocation between 2 chromosomes that results in a protein that causes cell division and survival. And the ALK negative, it looks exactly the same under the microscope, except it doesn't have this ALK protein. Why was that important? Well, subsequent studies showed that patients that had ALK positive ALCL not only were typically younger, there was more sensitivity to chemotherapy and higher cure rates. So these 2 entities were split off into different categories in a prior classification. Some other advances in classification comes from intestinal T-cell lymphomas. So the most familiar subtype is one that's actually associated with celiac disease. There's another type we call monomorphic epitheliotropic. It's a bit of a mouthful. That was split off because it actually looks very different at a genetic level and is more common in Asian populations. It was also recognized that some cases of that PTCL-NOS are just in the intestine, and so this was split off as a separate entity. And then there are some that are actually indolent and are really important for pathologists and clinicians to recognize because chemotherapy is typically not given because it doesn't impact the natural history. So I'm going to shift now to the rest of my discussion today on therapy advances, and I'll make some comparison to B-cell lymphomas. And I can tell you for T-cell lymphomas, it's more baby steps than leaps and bounds, but we have made some very positive steps forward in the last several years. So what are some of the challenges in managing peripheral T-cell lymphomas? And I'm trying to put a Canadian focus on it. It's rare, so as I mentioned already, there is also a lot of different subtypes. So not only do they represent only 10% of all non-Hodgkin's lymphoma in North America, under that 10% are 30 different diseases. So there's automatically going to be less clinical trials, less data, and there's less familiarity. So this is a type of lymphoma that's really important for us to come together as a community to learn from each other. And this is there has been a huge focus in doing that in the last really almost 15 years. It's been long recognized that peripheral T-cell lymphomas are more difficult to cure than diffuse large B-cell lymphomas. And this is even before rituximab. You've seen some of the other talks. You'll know that rituximab was a home run in B-cell lymphomas, and it sticks to a protein called CD20 and improved outcome. I'm showing you here curves from before we had rituximab, and even then, the outcome in peripheral T-cell lymphomas compared to the common aggressive B-cell lymphoma, diffuse large B-cell lymphoma, were inferior. So we've always had work to do. It's also recognized, though, that all peripheral T-cell lymphomas are not created equal. So not only are these diseases heterogeneous, the outcome is as well. And some actually do really well. And the best example is ALK positive ALCL that I've already shown. There's also cutaneous version of ALCL that has an excellent outcome. And there's also some that have a very aggressive course. So you can see that there is a spectrum. How do they present? Well, this is actually not something I could do justice in one slide, but just a couple of key points. On average, the age is between 60 and 65. As I mentioned earlier, ALK positive ALCL patients are younger and the average age is in the 30s. typically aggressive, but there are some that have a more indolent course. And usually people present with widespread and large lymph nodes, might have B symptoms, which are weight loss, fevers, and night sweats. We might see extranodal sites like bone marrow and gastrointestinal tract and skin involved. Most of the time it's advanced stage, and most of the time people feel unwell from it. This is the Ann Arbor staging for lymphoma that I suspect you've seen before, but we also apply to lymphoma with the advanced stages, stage 3, stage 4, with stage 4 just meaning extranodal sites of involvement. And as I mentioned, we also distinguish whether there's so-called B symptoms. What are prognostic factors? So these are always important for oncologists to estimate what we think the success of therapy is going to be. Again, we can only report on populations, but not individuals. But the International Prognostic Index is a prognostic indice that we use across a lot of different aggressive lymphomas, and it does apply in some peripheral T-cell lymphomas, and it incorporates 5 features: age, a blood test called the LDH, performance status. This is what symptoms a patient may have, the number of extranodal sites, and advanced stage. So there's a point for each of these, and the more points, the less chance of being cured. So this is just an example of what we see in peripheral T-cell lymphomas, and we actually can identify different risk groups by applying this. So this is useful for us, and it's useful for us to compare different studies and new therapeutics by stratifying based on this IPI. So what is the standard treatment for peripheral T-cell lymphomas? Well, the standard sort of backbone chemotherapy across aggressive lymphomas is a regimen called CHOP, with each letter standing for a different chemotherapy name. P is prednisone, that's a steroid. That's used because prednisone actually does kill lymphoma cells, so it is packaged into a lot of our chemotherapy regimens. Because of disease rarity, the data that we use to support use of CHOP was actually mostly borrowed from aggressive B-cell lymphomas. Taking the 2 more common subtypes together, the cure rate is about 30%, so suboptimal, and we need to do better. Sometimes etoposide is added to increase the dose intensity. We don't have firm data to show the benefit, but it is used in some cases, especially in younger patients. But as I mentioned earlier, as we're trying to improve outcome, there's interest in looking at new therapies to add to CHOP, and CD30 has always been a very attractive target for anaplastic large cell lymphoma, as well as some other peripheral T-cell lymphomas that may also express CD30. So what can we expect with CHOP-like regimens? So I'm just showing you a meta-analysis, which was a combination of 30 studies, but also our own BC Cancer experience. And I show it because this is my original interest in peripheral T-cell lymphoma actually started with this study that presented in 2000 when I was a resident, and carried the interest forward over the years. But the results were very similar in that about a third were cured with CHOP chemotherapy. We've already moved into an era where we're customizing the therapy for some peripheral T-cell lymphoma subtypes, and some good examples are a subtype called extranodal NK T-cell lymphoma. We don't see this very often in Canada, although a little bit more in Vancouver, as we have a higher proportion of patients of Asian descent. But we've learned that CHOP doesn't work, and the lymphoma is very resistant to it. So other chemotherapies have been tested, and in an advanced stage, chemotherapy called L-asparaginase has now supplanted use of CHOP. Also of interest, there's PD-1 inhibitors that are used across a number of cancers, as well as in Hodgkin's lymphoma, that show particular promise in this subtype. And that's because there's abundant target expression of PDL that's driven by the Epstein-Barr virus, which is also associated with this disease. Another rare subtype of peripheral T-cell lymphoma is called hepatosplenic T-cell lymphoma. These are patients that are often young men, and they present with enlarged liver and spleen and often unwell, and may have been on immunosuppressive therapy, for example, azathioprine for Crohn's disease. Again, this is a subtype where there's just outright resistance to CHOP, and so other non-CHOP regimens are now are preferred, along with stem cell transplant that I'll talk about in a moment. And then there's another rare type that is seen most commonly in Japan, also in the Caribbean, called adult T-cell leukemia lymphoma that's associated with the HTLV1 virus, and this is also a subtype that we no longer use CHOP for. But one area of interest is, and particularly in those three common subtypes that we've already discussed, can we add a drug to CHOP to improve cure rates? And the best success story that we've seen to date is use of brentuximab vedotin in CD30 positive peripheral T-cell lymphomas. This is an antibody drug conjugate that targets CD30. So antibodies were developed as cancer therapies in the 1990s. But the one that was against CD30 actually didn't work very well. So they went back to the laboratory to design something more powerful and attached another drug to the antibody. And the antibody takes the drug to the cell that expresses CD30. It gets into the cell and it kills the cell. So anaplastic large cell lymphoma was the obvious peripheral T-cell lymphoma to test this in because it had tons of CD30. So I've already described the mechanism, but after it gets into the cell, it actually interferes with mitosis, which is involved in cell division and ultimately kills the cell. So we first saw a study where brentuximab vedotin was tested as a single agent in patients with relapsed or refractory anaplastic large cell lymphoma, meaning they'd already gotten a CHOP or a CHOP-like therapy and it's come back. And it was a striking response rate, so 86%. So that means that 86% of the people had shrinkage of their lymphoma of more than 50%, and 57% had shrinkage that was so good that you could no longer see it on any of the scans. So this was quite impressive for a single drug. And so BV then became the first antibody drug conjugate to be approved by the FDA in anaplastic large cell lymphoma. It was also approved in Hodgkin's lymphoma, which also has the CD30 protein, in 2011, and then we finally got it approved in Canada 2 years later. So that's 10 years ago now. Because it interferes with mitosis, the main side effect is peripheral neuropathy, which is numbness in the hands and feet. So because this looks so good in the relapse setting, the obvious thing was, well, what about if we move it to the frontline setting? Can we cure more patients than using CHOP alone? So the best way for us to show that a therapy is better than a standard therapy is a randomized phase 3 study. And this is really what we need in Canada to actually get drugs approved. So CHP was added to brentuximab vedotin and compared to CHOP. Why don't we have the O? O, the other name for O is vincristine. So O is Oncovin, and the name, which is the trade name, but the real name is vincristine. And because that one causes peripheral neuropathy as well, we didn't want to have overlapping toxicity and really end up with people having numbness in their fingertips. And because vincristine was also not one of the bigger chemotherapy agents for this regimen, it was taken out. There was an earlier study that showed that this regimen was safe and looked promising, and then this landmark Echelon 2 study was then developed. So the people that went into this study are those with newly diagnosed CD30 positive peripheral T-cell lymphomas, and the plan was to have 3/4 of the patients to have anaplastic large cell lymphoma The reason behind that was this study was actually meant to be a confirmatory study for the original approvals, both in Europe and in Canada. So they designed it to have 3/4 of the patients, and they almost got there with 70%, which means we have the most information for ALK positive and ALK negative ALCL. But at any rate, this study has been published out, and it showed an improved progression-free survival. And this is actually a very good difference. It's 13% difference at 3 years. So from a physician standpoint, this is actually a very meaningful difference. The other thing we saw was an improved overall survival, which we don't always see initially because sometimes it can take longer follow-up, but this combination was so good, people were actually living longer. So this combination led to the fastest FDA approval that they've actually ever had in history. And in the States, everything happens much quicker, and they had approval in November 2018 in any CD30 positive peripheral T-cell lymphoma as per the definition going into the study. And Health Canada approved it a year later, and it's slightly different in terms of the approval language. It's approved in anaplastic large cell lymphoma, of course, but also CD30 positive NOS and angioimmunoblastic T-cell lymphoma. The tricky part is we don't know the benefit of that regimen in those non-ALCL subtypes because the numbers are so small. So we really have to make case-by-case decisions about it. I will also mention that enteropathy type T-cell lymphoma, that was the one that's associated with celiac disease, is usually CD30 positive. There was really, I think there was only one person with that entity that entered this study, but there is a separate study ongoing and it looks promising. So I hope that we can use that as ammunition to access this regimen in that rare entity as well in the future. So what about stem cell transplant? This comes up a lot in peripheral T-cell lymphoma because the relapse rate is higher with that CHOP chemotherapy. So the idea is to add dose intensification to improve those cure rates. So before I talk about transplant, I'd have to give you some definitions. So there's two types. One is called autologous. Auto means self. So this means that the stem cells come from the patient and they're collected at an earlier date. The idea behind autologous stem cell transplant is to give really high doses of chemo to kill the lymphoma cells, but the off-target effect is also killing normal B cells, which is why you need the stem cells from the patient to rescue. The other type of transplant is called allogeneic. Allo means foreign, and it also uses chemotherapy. Sometimes it's high doses, sometimes it's just mini doses, but it also has, in addition, the cells from the donor, which is usually a sibling, but sometimes unrelated, also provides part of the therapy in something called a graft versus lymphoma effect. The con of it is those same cells can attack the patient because they're seen as foreign, and some patients can have graft versus host disease, which may be very serious. As I mentioned, sometimes with the allogeneic transplant, we don't give high doses, we give mini doses, and the idea behind the mini doses is just to give enough chemotherapy to suppress the patient's immune system to allow this graft versus lymphoma effect. So this is what this is just what the auto looks like. As mentioned, the stem cells are collected at an earlier date, put in the fridge, and then after the chemo is given, they're infused back in. So there's two scenarios where transplant has been used in peripheral T-cell lymphomas. One is in primary transplant, which just means it's packaged with the initial therapy. And again, as I mentioned, it's to increase the dose intensity because we're disappointed with the results with CHOP. And usually the term we use is consolidative transplant. In order to proceed with that transplant, there has to be an excellent response to CHOP. And although there's no phase 3 flip of the coin studies, it's often recommended in peripheral T-cell lymphoma because of that high relapse risk. We also use it in people who have lymphoma that's come back from after their primary treatment. And and we give some type of salvage therapy and try to shrink the lymphoma and then move into the transplant. The allogeneic transplant, so it's sometimes it's used up front with very high risk peripheral T-cell lymphomas, so part of the primary therapy. It's commonly used in refractory peripheral T-cell lymphoma, and we use that definition for lymphomas that grow through their initial therapy or relapse early. And we also use it in the context of these mini transplants with more slow growing lymphomas. The challenge is always the donor source. Each sibling has a 1 in 4 chance of being what we call an HLA match. And graft versus host disease can be fatal, and it's too toxic for older patients. So there can be a limited role for allogeneic transplant. So I'm going to spend the last few minutes on new therapies and also highlight that the testing starts in relapse refractory peripheral T-cell lymphoma. So just like I reviewed with brentuximab vedotin. This is kind of a bird's eye view of how we manage relapse refractory peripheral T-cell lymphomas in Canada. The first decision point is whether we're planning to package in a transplant. So it's either transplant eligible or planned, or transplant ineligible. If the transplant's planned, then we're going to usually give second line chemo and try to get a good response and then move into the transplant. If there isn't a good response or transplant's not planned from the get-go, then there's a number of different options. And clinical trial actually is a really good option. But I'll talk about some other scenarios in upcoming slides, as well as some studies that are ongoing. So what do we have available in Health Canada? And I just showing you a comparison to the US. I wish this list was longer because we have more difficulty accessing drugs that aren't Health Canada and, of course, provincially funded. We have pralatrexate approved. We did have romidepsin, but I'll talk about that in the future. Unfortunately, that was withdrawn this year. We have brentuximab vedotin for relapsed ALCL. And we don't have another HDAC inhibitor called belinostat, and we don't yet have crizotinib, which is an ALK inhibitor that's also available in the US. So I've already talked about brentuximab vedotin, just looping back to it because it was one of the first drugs approved in relapsed refractory PTCL. It's only approved in ALCL, but in some provinces it may be accessed for other CD30 positive PTCLs. I'm just summarizing the response again. The expected duration of remission is about a year. And as I mentioned, the main side effect is numbness in the hands and feet. But there are some patients actually that get even more durable remissions. And we do sometimes see long-term survivors. So it can be curative in rare patients. Pralatrexate was actually the very first drug to be evaluated specifically in peripheral T-cell lymphomas, and that was because it seemed to show, excuse me, selectivity in T-cell lymphomas compared with B-cell lymphomas. This led to a phase 2 registration study. Although the response rate was only about 30%, there were some patients that had meaningful benefits. And since the original report, there's been subsequent studies changing how it's given to reduce toxicity because it could cause mouth inflammation and low platelets. It was Health Canada approved in 2018, and it's available across a broad range of relapsed refractory peripheral T-cell lymphomas. I want to talk about the T follicular helper lymphomas in the context of relapse refractory PTCLs, because I think it represents a really strong argument for more personalized therapy, which is also why it's really important to recognize the other TFH lymphomas outside of angioimmunoblastic T-cell lymphoma. Why is that? They all share a characteristic mutation profile. So I'm just showing you a picture from a study that was published looking at mutations in different genes. And if you look at the ones I've highlighted in the red bracket, each black square refers to the presence of a mutation, and each column is actually a different tumor sample. So just to give you an idea of the frequency of these mutations. But across a number of studies, it was determined that as a group, these TFH lymphomas have a very characteristic mutation profile. And there's building evidence over the last several years of sensitivity to a category of drugs in a category called epigenetic modifiers. And I'm just going to show some examples of this. Some are HDAC inhibitors, hypomethylating agents, AZH2 inhibitors, and what we call IMiDs like lenalidomide. And so now physicians can make more rational drug choices for patients if they know they have this particular lymphoma. So it allows me to tailor my therapy a little bit better. So the first example of this was actually the histone deacetylase inhibitors. So HDACs keep the DNA really tightly wound, so certain genes can't be transcribed. HDAC inhibitors loosen up everything to allow transcription of genes that are involved in killing cancer cells. The two that were under development in peripheral T-cell lymphoma are romidepsin and belinostat. Romidepsin was actually approved in Canada in relapsed refractory PTCLs 10 years ago. But unfortunately it was withdrawn this year because there was a phase 3 flip of the coin study that did not show a benefit of CHOP and romidepsin compared to CHOP alone. The problem is it was all types of PTCLs, and if you actually just pull out the TFH lymphomas, there did seem to be a benefit. But unfortunately, because this drug approval was tied to that confirmatory study, it was first withdrawn in the US and more recently in Canada. Belinostat is another HDAC inhibitor from another company that is available in the US but not available in Canada. And I've been pestering them to bring it to Canada, given that we've lost romidepsin. But as of today, we don't yet have that available. But I wanted to mention it because it was the first example of how we can sometimes see durable remissions in these TFH lymphomas with these type of epigenetic therapies. And this was a long-term follow-up study of patients with angioimmunoblastic T-cell lymphoma that were enrolled in the original study with romidepsin. And there was a few patients that were remaining in complete remission for over 3 years. And normally the benefit for these types of agents is sort of 3 to 6 months. So, and this suggests that maybe there's actually a minority that are even cured. Of course, we need really long-term follow-up to say that. But I've certainly seen this in my own practice, some durable remissions. So I hope there's a way for us to access these drugs in the future. The other really promising drug in this group of TFH lymphomas is 5-azacitidine. This is a hypomethylating agent. I'm just showing you a very small study in angioimmunoblastic T-cell lymphoma, but that showed a very promising overall response rate. So there was a small pilot study adding azacitidine to CHOP that was actually published in the Blood Journal this year. It's only 20 patients, but the results looked better than what we would expect with just CHOP, with a 2-year progression-free survival of almost 66%, and most of the patients had TFH lymphomas. So there is a larger study being evaluated right now in the US, and I hope maybe we'll see this regimen in the future. Other drugs that look promising in TFH lymphomas that may also be applicable in other lymphomas. I've divided them into drug categories. There's targeted therapy, a drug called duvelisib, which is a PI3 kinase inhibitor, and that's involved in T-cell receptor signaling and drives T-cell growth. There was a a phase 2 study, and I suspect that that drug will probably be approved in the US very soon, and hopefully we'll get it in Canada. Ruxolitinib is a JAK inhibitor, and there are some PTCLs that have this pathway active that may have a role. Valimetastat is an AZH2 inhibitor, and I think we're going to be seeing data about this study at our big American Society of Hematology meeting in December. It looks quite promising in TFH lymphoma in the early studies. In the immunotherapy realm, there's PD-1 inhibitors, as I've already mentioned, the rationale specifically in NKT cell lymphoma. CAR T-cell therapy has really revolutionized some B-cell lymphomas. We're a little bit behind in T-cell lymphomas, but there are some studies ongoing in the US looking at different targets, including CD30. And then there's also some therapies directed against lymphomas that have expression of EBV. There's other drugs that may not be approved or funded, but in some scenarios we might be able to access lenalidomide as well as 5-AZA. Big plug for clinical trials, which are always appealing for T-cell lymphomas because it allows us to access drugs we wouldn't otherwise be able to access for patients, and in some cases can lead to practice changes and changing even the overall treatment paradigm. I'll just end with just letting you know that we do have challenges in accessing drugs in Canada. I worked very briefly in the US, and there's pros and cons. The US is great if the patient have insurance, but if they don't have insurance, they can't access anything. So I think overall our system is good, but it can be frustrating at times, and it can be frustratingly slow. I mentioned already brentuximab but vedotin and pralatrexate are the only provincially funded drugs, and BV is only an ALCL technically, but a lot of provinces will approve it in other CD30 positive PTCLs in the relapse setting. BV chip is available in ALCL, AITL, and PTCL-OS that are CD30 positive. Unfortunately, I already mentioned that what happened with romidepsin. I hope that it's just a lull, and maybe we'll be able to get another HDAC inhibitor. And sometimes physicians have to submit through Health Canada, and some cases there might be extended health that a patient has. So sometimes we need to do a different path to try to access drugs for patients in Canada. So just to sum up, I think I've hopefully shown that not all peripheral T-cell lymphomas are created equal, and we've definitely moved away from a one-size-fits-all. I've shown that CHEP-BV is a new standard in ALCL. We're a little more uncertain outside of that indication. Consolidated transplant, I think, still does have a role in younger patients. And as I mentioned, personalized therapy is also here already for TFH lymphomas. That's a group that we can be very thoughtful in what we should select. And a big plug for clinical trials. That's really how we move this field forward. And also for us, because we're working in rare diseases, we come together as a community to share experiences and pool databases for outcome analyses. Thank you for your attention, and I am happy to take questions in the Q&A. I hope to see you there. Thank you.
Thank you, Dr. Savage, for that great presentation. We appreciate your thorough review regarding disease-specific biology, diagnosis, and treatment options. So now, just as Dr. Savage just said, I'd like to direct the audience to attend the T-cell lymphomas Q&A session after this presentation to have your questions answered live. Thank you, everyone.